So let's just dive right into our agenda. We'll be defining daycare surgery, looking at who qualifies, navigating anesthesia risks, reviewing the safe discharge checklist, and finally, unpacking the secret sauce, ERAS protocols.
Okay, Section 1, Defining Daycare Surgery, the Sunrise to Sunset Rule. To really grasp daycare surgery, we've got to rigidly define our timeframes, because in the medical world, time is everything. Daycare surgery strictly means the patient is admitted and discharged in under 12 hours. That's a massive difference from an overnight stay, which clocks in at 23 hours, or a short stay that can take up to 3 whole days. So just remember that magic number, strictly under 12 hours. Now, you might be thinking, isn't that just an outpatient clinic? Well, actually, no. We have to separate daycare from outpatient setups, which have no ward admission at all, and procedure rooms, which don't even need a full sterile theater. A perfect example of that would be a quick breast biopsy for a benign lump that's done right in an outpatient room, and the patient leaves in an hour. Daycare is a whole different beast.
Moving right along to Section 2, Who qualifies for daycare? Strict patient selection. You see, not everyone can just walk in and out on the same day. It's an absolutely rigorous selection process, and surgeons care way more about your physiological age than your chronological age. If you're running a standalone daycare unit, you can safely take ASA grade 1 and 2 patients, basically healthy folks, or those with mild systemic disease. But if you've got an ASA grade 3 patient, they absolutely have to go to an integrated daycare unit attached to a main hospital. That way, if things go south, full hospital resources are right there.
Body mass index, or BMI, is another huge factor. For a surface procedure, the patient's BMI strictly has to be less than 40.
Actually, scratch that. If we're talking about a laparoscopic procedure, that threshold drops. For laparoscopy, they have to have a BMI under 38 to qualify.
What about diabetic patients? Well, their HbA1c needs to be under 8.5. Plus, they always get scheduled first on a mixed surgical list to minimize their fasting times, and they'll usually skip their morning oral diabetes meds.
But you know, it's not just about the medical numbers. The procedure itself has to be under 2 hours, blood pressure strictly under 180/100, and things like epilepsy must be completely controlled. But maybe the most absolutely crucial part? The patient must have a solid social support system. They need a responsible adult with them for the first 24 hours, especially elderly patients, and they have to live reasonably close to the hospital just in case.
Right, Section 3, Anesthesia and Complications, Navigating the Risks.
Once our patient is carefully selected, the anesthesia needs to be completely dialed in for a rapid, smooth recovery. The absolute gold standard here is TIVA, or total intravenous anesthesia, using propofol. Why? Because propofol massively cuts down on postoperative nausea, which gets you recovering faster. We pair that by infiltrating the site with long-acting local anesthetics, like bupivacaine, to keep the pain away for hours.
And trust me, we want to avoid nausea at all costs. The source material shares this vivid story of being on a small whale-watching boat in South Africa, passing a bucket around as the waves just completely wrecked everyone. Waking up from surgery feeling like that? No way. That's why surgeons use the APFL score to predict nausea and completely avoid drugs like morphine.
But honestly, nausea isn't the most dangerous risk. Bleeding is. Specifically, reactionary hemorrhage, which happens 4 to 24 hours after surgery because a clot dislodges or a knot slips. To stop this from happening at home, surgeons use a brilliant trick. Before they close the skin, they have the anesthetist bring the patient's blood pressure right back to their normal, awake baseline. Because if you close them up while their blood pressure is artificially low, the second they wake up and it spikes, those closed vessels can pop right open.
There's a really terrifying anecdote in the source about a young fast food worker who had a daycare procedure for a testicular tumor. While he was in recovery, a nurse noticed his vitals dropping. Within just 15 minutes, he was in shock. They rushed him back to the operating table and found a massive pool of blood from a slipped ligature. Covert hemorrhage is absolutely no joke, which is exactly why Hawkeye vital monitoring is non-negotiable.
Okay, Section 4, the Safe Discharge Checklist, Earning the Ticket Home. To make absolutely sure tragedies like that covert bleed don't happen in a patient's living room, hospitals use an uncompromising checklist. You literally have to earn your ticket home. Vitals stable for a full hour? Check. Fully oriented? Check. Passed urine? Kept fluids down and no dizziness? Check. You even have to be able to dress and walk. And that responsible adult we mentioned has to be right there, understanding exactly when to rush back to the hospital. And here's a massive deal breaker: pain management.
If a patient is still needing IV painkillers to manage their pain, they are absolutely not going home. Being able to rely strictly on oral analgesia is a hard requirement for discharge because it proves they can handle it independently.
Finally, Section 5, Enhanced Recovery Protocols, or ERAS, the secret sauce.
So how on earth are all these rapid, same-day discharges possible for complex things like hernia repairs? It's ERAS. This protocol completely blows up the outdated fast from midnight rule. Now you can eat solid foods up to 6 hours before surgery and get this, clear, carbohydrate-rich liquids up to just 2 hours before. It keeps you hydrated and energized. Then, just 4 hours after surgery, you're taking sips, and within 24 hours, you're up, walking, and eating normally.
EROS is a total game changer from start to finish. It starts with comprehensive patient counseling, because setting the right mental expectations actually speeds up physical recovery. We also ditched the old mechanical bowel prep. No more enemas that just leave you severely dehydrated. During surgery, the patient is kept warm, and we go for minimally invasive techniques. Afterward, no unnecessary drains, no nasogastric tubes, and we stop IV fluids fast. We are literally removing metabolic shock from the equation, so the patient can get back on their feet immediately.